So hey guys, welcome back to another lecture, and this is going to be the part 2 of oral anti-diabetic drugs, and this is going to be a medicine lecture. And in previous video we have discussed drugs which helps us overcome insulin resistance for our type 2 diabetic mellitus patient, right? Metformin and pioglitazone. Now today we are going to discuss our insulin secretagogues, which means drugs which increase insulin secretion in type 2 diabetes mellitus patient, right? So they are potassium ATP channel blocker in beta cell of our pancreas, right? So the drugs are the two groups which are meglinitide or phenylalanine analog or SU sulfonylureas, right? So this is a sulfa group, so there will be a sulfa reaction with it. So remember that from the name only. There is a first generation and there is second generation, right? Tolbutamide is the first generation sulfonylurea, and glibenclamide, glipizide, gliclazide, and glimipride are the second generation sulfonylureas, right? So meglinitide and phenylalanine analog, repaglinide and netaglinide are also oral drugs which we will study in deep, right? So first we will start with sulfonylureas. So let's move forward to it. So let's learn the mechanism how our insulin secretagogue sulfonylurea and meglitinides work, right? So what happens is that drug comes and bind to the ATP sensitive potassium channel in our beta cells of pancreas, right? So potassium will not be able to go out of the cell, and that will lead to increased cations in the beta cells, and that will lead to cellular depolarization. And because there is a specific voltage attained, the voltage gated calcium channel will open and there will be calcium channel influx. Potassium calcium channel will come inside and will create or signal insulin release, right? So that insulin will act on GLUT4 receptors and open it, and the peripheral cells and the blood glucose level will be fall down because they will be utilized by peripheral cells, right? So this is the mechanism of action shortly of sulfonylureas and magnetides. Basically they increase insulin secretion, right? So this to be worked, there is a requirement of 30% functional beta cells, right? Because as the time goes and patient is very insulin resistant, so there will be loss of beta cell exhaustion, and sulfonylurea and magnetide might not be useful drug at that time. So sulfonylurea and magnetides require 30% of functional beta cell mass, right? So this is the mechanism of action and the key difference. Yes, there is some difference of action in magnetide and sulfonylurea on a receptor basis, but that is not very important in practical life. Practical life, what is important is sulfonylureas stimulate the pancreas to release insulin over a period of several hours, right? So it secretes insulin and it is maintained for a while. The action is maintained, right? But meglinitides action differs here from SU sulfonylurea, that they are stimulated by short-term burst of insulin. So their half-life is shorter. So this both drug control PP2BS, right? But sulfonylurea can control overall blood sugar level, while meglitinides can't, right? So understood? This was our mechanism. Moving forward, now let's learn about the drugs. So sulfonylurea are insulin secretagogues, and now understand these both drugs are increasing insulin secretion. So with this, there will be a risk of hypoglycemia. These drugs will cause hypoglycemia if the dose is excess, or if there is skip of a meal. If patient skips the meal and takes sulfonylurea or meglitinides, there will be hypoglycemia. Remember this. So we have learned the mechanism. We require 30% beta cell mass, so saying sulfonylurea can work, right? So first generation is tolbutamide, which is not now recently used because we have higher second generation very potent drugs, right, which acts for long term, right? So there is one drug which is very potent and acts for a long time is GLIMIPRIDE, which is usually prescribed alone or single therapy, monotherapy, or in with combination with metformin, right? So GLIMIPRIDE is very important, and that is available in 1 mg, 2 mg, 3 mg, and 4 mg, and can be given once daily with first meal. So because GLIMIPRIDE will act longer, so it will control high average blood sugar levels, right? So there is gliclazide immediate release and modified release. These are the doses 40, 80, 160, and modified release are 30, 60, right? So glipizide is 5 mg and it's initially 2.5 to 5 mg daily. Take shortly before breakfast or lunch, right? With glipizide, you have to take it before breakfast or lunch up to 15 mg. Maybe given a single dose or higher doses, which if you go for 20 mg per day, you need to give it in divided doses. Tolbutamide is generally not prescribed these days, right? So they control mainly PP2BS or average blood sugar level. So we have to take it before meal, right? Glimipiride, glipizide, and it can be taken with meal, gliclazide drug. Now, coming toward the sulfonylurea, metabolized mainly in liver, so right, and its second gen, which is our glipizide, glimipride, are excreted in bile, so they are relatively safer also. Now, adverse effect is if they are secreting insulin, and insulin can also cause weight gain. So these drugs increase weight in patients. So it is, yeah, that is one of the adverse effect, but that is only for the first year of use. From second year, that might be very low weight gain in that patient, right? So that is only for first year. So you can easily prescribe also. There is no need for worrying about the weight. Now, as we have learned that it can cause hypoglycemia, and the point to remember here is that to counter hypoglycemia caused by sulfonylurea, we have to give antidote octreotide, right? So this is the high thing to know, that hypoglycemia caused by sulfonylurea, the antidote you will give is octreotide, right? So you need to reduce dose in liver and kidney disease. As you have learned, it is metabolized in liver, right? So we have to reduce the dose in liver and kidney diseases. In elderly patient, we have to reduce the dose of sulfonylurea because yes, this drug causes hypoglycemia, alright, and it is also caution to use and contraindicated in G6PD deficiency. And as the name suggests, they are sulfonylurea, right? So they will have sulfur risk allergy patient, which you need to be avoiding, right? So now you understood that sulfonylurea cause insulin secretion, right? So they cause hypoglycemia. So whenever the patient skips meal, for example, if patient is fasting state, like for surgery, investigation, or during Ramadan, in any case patient is fasting, there will be a very increased risk of hypoglycemia, right? But there is less risk if the hypoglycemia, if patient is stable SU dose, which means the dose we have not been adjusted a very long time. The patient is on a stable dosing at least 3 months prior to Ramzan, right? So there will be less chance of hypoglycemia, but there is also some chance. With glipizide, glimipride, and gliclazide, there is less chance because they are very potent drugs for longer time. They don't act in short bursts, so we can prescribe. Take once daily dose at iftar, at sunset, and twice daily, then usual dose at iftar, and consider reduced dose at sunrise. If you want to prescribe twice, then you need to reduce the dose of sunrise, the first meal, right? And at iftar, we can give the regular dose because the patient is going to have meal. So this was a quick update on fasting cases of sulfonylurea as you have learned today. And when to avoid risk of hypoglycemia, what you will do? You will start the doses slow, right, and titrate according to blood glucose level. and you will guide patient to self-monitoring of blood glucose level. Patient has to monitor this because if you are starting it new therapy, the patient needs to monitor or patient will have hypoglycemia, and you have to explain the symptoms of hypoglycemia. And also take note that beta blocker, which are non-selective, beta 1, beta 2, both acting beta blocker is patient in the patient, they can mask the symptom of hypoglycemia, which is tachycardia. A symptomatic action is blocked. Right, so first generation we will not talk about because that is not practically used anymore. So let's come towards second generation, and they are 100 to 200 times more potent than tolbutamide. Right, used with caution in cardiovascular patient and elderly patient. Right, because that can cause prolonged hypoglycemia, can be dangerous in this kind of patient. Right, so let's come to our first drug, glyburide, as in US, but in India we say glibenclamide. So don't get confused here. Glyburide is used in US based textbooks, where glibenclamide is available in India. So they are both same drug, but the name is different in India, which is glibenclamide. You will read it in KD Tripathi, but in CDMT you will read glyburide. Right, so should start the dose from 2.5 mg, and the maintenance dose is 5 to 10 mg per day. Right, higher than 10 mg per day is not recommended for glibenclamide. Okay, and this is the single morning dose. So it is metabolized in liver, so metabolic product have hypoglycemic effect. Right? So there is some persistent 24 action, because after metabolized, the metabolic product also has hypoglycemic effect, so there is a long term action, and so because of that they can cause prolonged hypoglycemia. So avoid in older patient who has liver failure or chronic kidney disease. Coming to the Indian branch, Euglycon is glibenclamide 5 mg, Glibovin of 1.25 mg is also available, and glibenclamide Glibovin 2.5 mg is available. So let's come to the glipizide, right? So start with 5 mg per day dose, right, and move titrate slowly to 15 mg per day single daily dose. Now, if more than 15 mg is required, then you have to give it a divided dose BD, and which is given before meals, right? So maximum dose you can give is 40 mg per day, but about 20 to 15 mg, very little benefit is shown. So better move forward to dual therapy or triple therapy in the patient, right? So maximum benefit of this drug is seen in postprandial blood sugar level, so decrease PP2BS, right? And glipizide you should take before 30 minutes before meal, right? Why? Because if you take with food, the rapid absorption action of the bursting action is not be taken under control, right? Because sugar will not be controlled if the drug is not reaching in time to secrete insulin and control the postprandial blood sugar level. So the thing is, take before 30 minutes of meal, right? So 90% of glipizide is metabolized through liver, 90, and only 10% is excreted unchanged in urine. So this drug is strictly not used in liver failure, right? Now, if you want to give an sulfonylurea, you can give glyburide in elderly CKD liver failure, but in very low dose. Why? Because it is preferred over glipizide. The reason is because glyburide is very less potent and has very short duration of action than glipizide. If you have to choose a very low dose sulfonylurea in elderly CKD or liver failure, you can choose glyburide or glibenclamide, alright, but not glipizide. Okay, so glipizide is also available in XL, extended release, and because of that, there can be a transit through GI tract, and which can lead to greater effect of fasting blood sugar level, which is generally high, right? So the immediate release tablet is just used where there is no advantage over glyburide. So glipizide XL has advantage over glyburide that can control fasting blood sugar level. Extended release has benefit over glibenclamide, right? So brand name in India, Glinase 5 mg, Glinase XL, which we have learned that XL use, right? So Glinase XL 10 mg is also available. Coming forward to gliclazide. Gliclazide is an intermediate duration of sulfonylurea, comes between all the potent and less potent drug. Gliclazide comes in between. So the duration of action is 12 hours. The initial dose is 40 to 80 mg per day, and max which can be given is 320 mg, right? Dose above 160 mg given as divided dose. So you can give 160 mg single dose, but above 160 mg you need to go divided dose before breakfast and dinner. Remember this, before breakfast and dinner, right? And this is also metabolized in liver. So coming towards the brand name, Reclide MR 30, Reclide XR extended release is also available 60 mg, and Glyconom 80 mg. So these are the brand name of Reclide. Let's quickly move forward to our main drug, which is very commonly used and which you need to prescribe in this kind of patient, type 2 diabetic mellitus. So that is GLIMIPRIDE. Why? Because it has lower duration of action, controlling PP2BS and also fasting blood sugar levels, right? So the half-life is 5 hours and once twice daily dose can be given, right? So BD dose can be given. Achieve blood glucose lowering with lowest dose of sulfonylurea compound, right? So it attains very best result. A single daily dose of 1 mg per day is very effective. So maximum dose you can go is 8 mg, but that need to be divided dose. This drug also is metabolized in liver. Coming forward to the brand names, Amaryl, Glimipride 1 mg, Glycomet GP is also available, where there is 3 mg Glimipride and 850 mg metformin. So combinations are available, yes. Metformin hydrochloride prolonged release is also available, right? With metformin and Glimipride combination, 2 mg. 0.5 mg combination is also available, and 2 mg metformin 1 gram is also available. So yes, very commonly used. So you need to know this, that this need to be prescribed with metformin as a dual therapy. So let's come to our second insulin secretagogue groups, meglinotides. So in this group there are two drugs, both available in market, repaglinide and netaglinide. So starting with netaglinide, it is started and maintaining dose is 120 mg TDS, but if HbA1c is mildly elevated, 60 mg. Right, so we have learned what is the insulin secretagogue. Meglitinides act is short burst of insulin secretion. Right, so this is both the drugs are given 3 times a day, TDS. The repaglinide half-life is very short, 1 to 2 hours, so given 3 times a day. So half-life is short, action insulin burst secretion, so it is given before meal, right, and for 3 times a day. Adverse effect will be, because it secretes insulin, there will be weight gain, and obviously there will be hypoglycemia. So for repaglinide, what is the starting dose? 0.5 mg TDS 15 minutes before each meal. It can be titrated toward the maximum daily dose 16 mg. So what are the brand available? Torrent Pharma gives us Urepa 0.5 mg, also gives us 1 mg, 2 mg of repaglinide. And netaglinide is brand name is Netamed in India, and sustained release tablet is also available. So if you have learned anything in this video, hit a like, give a comment. Thank you for watching this beautiful video.